nice little group to start. And you want to be conscious of your time, so we'll get started. Today is our third Degmeyer Academy presentation for the Lunch and Learn sessions. We have our special guest, Sarah Martinez, who is one of our certified practitioners. She's a certified prosthetist orthotist who works primarily out of our Easton office location, but you will see her occasionally at our Linthicum office as well. She's going to be speaking today on setting appropriate prosthetic expectations for your patients. So I will let Sarah take it away.
All right. Hello, everybody. Angie, thank you for the intro there. Again, thank you to everyone here that's joining and taking the time out of your day to be here and to listen, learn, and eat some lunch. Hopefully you guys are taking the time to eat and relax. All right. So without further ado, prosthetic expectations. So just to be clear, I'm going to be talking about lower extremity prosthetics. The conversation for upper extremity prosthetics is a little bit different, and that could be a topic we entertain in the future if there's interest. So let us know. All right, let's go to the next slide. Okay, so with setting expectations, we need to know what the definition of an expectation even is. So a strong belief that something will happen or be the case in the future. Provides guidance and clarity of outcomes. So for a patient, some of those questions that involve setting expectation is, when will I walk? When can I put on a prosthesis? So we're going to cover that a little bit later, but I wanted to pinpoint so that we all have a foundation of what an expectation is. Next slide. All right, so keys to effective expectation setting. This is from, let's see here, the strengthscope.com. I was looking into different type of leadership tactics, but I think this is applicable in everyday life, between colleagues, at home, at work. Expectations are important basically anywhere with anyone that we're having interaction with. So number one, set expectations that stretch and inspire excellence. So we hold people up to a high expectations, at least I would hope. But we also want to be realistic of what those expectations look like. We do want to challenge people so that they can reach their utmost potential. Again, it is important to be realistic with those expectations. So ensure that you're clear on what those expectations are, and ways that we can go about the clarity of expectations is to either write them down or to articulate them. So communicate. Have that verbal exchange with somebody when you are developing expectations. So discuss wherever possible, agree expectations. I know the wording on that, number 3, is a little bit odd, but it's straight from the site. But in terms of sharing your expectations, not only do you want to get them on paper or share them verbally, you want to get some input too, because your expectations are one-sided, just in your mind. And so getting somebody else's viewpoint can let you see your expectation from a different perspective. Number 4, encourage the team to share their expectations of you. So if we're talking about a clinical setting, it's important for us to have our patients know that they can ask us, hey, or tell us, I expect this from you, so that we have this even ground of, here are my expectations for you, and vice versa. So we share and we listen to those expectations. Lastly, communicate your expectations relentlessly. So in an office setting, this is a pretty basic example, but being on time, right? So if I'm telling everyone, hey, I need you guys to be 5 minutes early, and I show up 10 minutes late, I'm not really setting an example from an expectation. So we want to practice what we preach. Next slide. All right, y'all. We might need to do one more click so that top box comes in. Okay, so starting off on the right foot or left, but making sure that we figure out why our patients are in the office is important, whether that's getting a prosthesis, doing a consult. It's important to know where they're coming from. So I have these 3 tabs, and we're going to touch on each one lightly, and then we'll get into the process of starting from the amputation to a diagnostic fitting, because that's a really crucial time in which we want to explain to our patient what their expectations are and what steps are are going to be happening throughout the process. So let's go ahead and move on to the next slide. Oh, and one more thing from the previous slide. So we have the patient, the prosthetist, and the physical therapist. I want to focus on this trio today. As we know, there's a lot of other team members or people that are involved within the plan of care, whether it be the patient's family, their case manager, the physician, the surgeon. But I know that there's a bigger picture of a team, but I want to again focus on these three people. So starting off with patient goals. Here are just some questions that I jotted down that we can ask our patients and be creative with these questions so that we can learn and gather more information. So what are your goals with your prosthesis? Oftentimes we'll get from the patient, I want to walk, I just want to move, I want to be independent. And so it's important for us to take those answers into account and deep dive a little bit more. Okay, you want to move, where do you want to go? What kind of things do you want to do? So then we follow up with what activities, hobbies do you participate in? And what keeps you busy and moving? And lastly, this question is a little bit out there, and I haven't asked this to a patient, but in my thought process of what else can I ask? What else can I include here? I thought to put in, what are some places that make you happy? So the patient could respond gardening or being at the park. And so we have these responses to a unique question, and we can further deep dive and investigate to see, all right, so if they like to garden, they like being outside, we can confirm with them that are they kneeling down? Are they stepping over dirt? So these are all clues for us as prosthetists to make sure we're gathering enough information to set up our patient for success. All right, so patient goals. This is from the Center for Creative Leadership, and I really love this photo, and we're gonna walk through each of these numbers and photos together. So 6 keys of active listening skills. Listening is a lifelong skill, and I am working on it every single day. I hope to get better because listening is an actual skill in terms of the comprehension and following through to implementing what you are hearing from the patient. So number 1, we want to pay attention. So it's when we're listening to a patient and we're hearing their story, it's very easy to get sidetracked and be on our computer typing up all the information that we see, but our body language isn't connected or directed to the patient. So it's important to keep in mind that our body language also speaks a lot more than what we're saying verbally. So paying attention to the patient, making eye contact, facing your body towards them, and when necessary, setting the laptop aside and focusing on them. And we want to make sure, number 2, we're listening without judgment. So withhold any preconceived judgment that you might have. You want to listen for what the patient has to say and take it at face value. After we've listened to what the patient has to say, we reflect on that information. And whether it's quietly in the peace of your desk, you want to listen or not so much listen. You want to just sit down and go through all of that information. And if you have any questions, number 4, you either call the patient or you look at the doctor's notes and you can clarify what questions you might have. And then at that point, you're summarizing everything that you've heard. And for this share option, I didn't read this one specifically, but we can imagine, like, from the photo, you're listening to their experience, you're listening to what they have to tell you. And from that information, you're gathering a game plan, you're gathering a treatment plan to share back with the patient. So it's a mutual exchange of information and listening on both parts. Next slide. All right, y'all. So now we're in that second box, which is the prosthetist goal. So we've got 3 boxes and then 1 box at the bottom, so 4 total. The first box is we want to ask questions. We're gathering medical history because that's going to give us some insight into what the rehabilitation process might be for our patient, especially if they have had several surgeries over the past couple months or a year, if they had a traumatic incident. So that's going to give us clues into how we proceed. We ask questions so that we can understand the patient's goal, whatever it might be. And next, we have all this objective information that is crucial. So we evaluate skin integrity. Depending on the skin integrity of our patients, if the skin is intact, excellent. If it's not, and there's burns, there's grafted tissue, there's scars, we need to make sure we take that into account, because that might mean we need to approach things a bit more differently in terms of, say, a custom liner for that patient's skin so that they tolerate wearing a prosthesis well, and we can accommodate any type of skin differences. So sensation, do they have excessive pain or do they have no sensation at all? That's also very important for us to know so that we can educate our patients appropriately on what to look for once they do start wearing the prosthesis. Outcome measures like the AMP Pro or the tug test, this is going to help us determine our patient's K level or activity level. And we'll get into K levels in a moment, but I'm just throwing that out there, planting that seed for now. Evaluate strength and range of motion, balance. So in our evaluation of the strength of motion, the balance, this is all just giving us more information so that we can make that prosthetic prescription for our patients, and we can provide them with the appropriate expectations. Lastly, we're formulating our prosthetic prescription. So what components will help my patient achieve their goals? We perform these outcome measures, and the patient may test as a K2 or a K3, and I'll go into K levels now. So we have K0 all the way up until K4. K0 means that the patient is not a prosthetic candidate, whether that means that they are extremely weak, they lack motivation, or they have a severe type of contracture that's going to make it extremely difficult for them to walk. So at that point, say it's a contracture, then we would refer the patient to physical therapy to see if they could work that contracture out. A K4 patient, you want to think of your athletes or children. So their activity level, their impact level is very high. They're the hardest on their prosthesis, so they need something very durable. And in terms of K2 and K3, so the definition goes the ability or potential to ambulate. And the biggest difference between K2 and K3 is that K2 is at a single cadence and K3 is a variable cadence. So the patient is able to walk slowly across the street, and if that light is turning yellow, turns red, they can giddy up and walk across the street quickly if they need to. So once we know what the patient's K level is, based on their outcome measures, based on the activity that they used to do prior to the amputation, we can then determine, okay, the patient would benefit or has the potential to benefit from a K2 or a K3 foot. So lastly, and I included a little light bulb in here, but because it's important to establish a common goal with your patient. They have their goals, we have our goals as healthcare professionals, and it's important to verbalize that goal with your patient, right? It's easy to just have the goal in the back of your head and go through the routine and listen to your patient's goal and say, okay, I hear you, here are the steps we're going to take to get there. But it can be helpful for your patient to know that you also have a goal for them, and then establish that rapport, create that trust and that team approach on their rehabilitation journey of walking with a prosthesis or wherever that goal might be. So let's go to the next slide here. All right, so short stories, managing expectations. I'm going to get into a quick little story here that I'll share with you all. Navigating eager to walk patients. So we have a quick background. So the patient's age 60 years old, the weight is 235 pounds, male, K3, or ability and potential to be a K3 ambulator, brand new patient. And he has a history of diabetes, vascular complications, and occupation self-employed. So this is an important story for many reasons, and I share this with you because it was a learning experience for me. So you can tell me whether or not expectations were set or not in the chat if you'd like to participate. So once upon a time, I was a resident and a patient asked me, this patient had asked me, all right, so when can I walk? And based on all of the objective information, his range of motion, his range of motion was good. He tested high in manual muscle testing, 5 out of 5. The suture line was all healed. And so all of this criteria was an indicator for me, oh, you're going to be back up and walking pretty soon. So I responded to him, we'll get you back up walking in a few weeks. So the next step is that I cast the patient over his liner, and on our end, we begin to fabricate what's called a test socket. And I have a test socket right here. And I'll go into a little bit more depth of why we do test sockets in a moment. So we schedule the patient back in, and the test socket's all ready. He dons his liner, and I go to put on the test socket, and it doesn't fit. So the patient's volume had changed, and the modifications that I did to the socket were too much. So it was just too tight. So I go back to the lab and I put some fire on this, some heat, and I tried pulling out the plastic. The nice thing about using this plastic material is that it's heat moldable. So in circumstances like this, we can apply some heat to this material and then pull it out to allow the patient to go further down into the socket. Although it helped, it didn't solve the problem that we were facing. And so the patient wasn't able to get distal line contact, and the result being that he was unable to walk that day because we did not have an appropriately fitted socket. So that lesson, that experience taught me to think more carefully about how I explain to the patient what the next steps are. Because sure, if everything worked well and the patient's volume stayed the same and my modifications were maybe a little bit less, we could have had him up and walking that day. However, all those steps, all those variables didn't necessarily fall into place. So it was a bummer, but it was a lesson in how to explain appropriately to the patient. So next time, what I would have done was tell the patient and answer the question, when can I walk? Well, you know what? First, we got to get you into an appropriately fitting socket. And then the next step is we need to make sure that you tolerate weight bearing in that socket well. So that's what I learned from that situation. Bear with me. I'm currently in the kitchen and we have a loud noise going on right now. It should go in just a moment. All right, let's go to the next slide. All right, can you guys hear me okay? Good, okay. All right, so now we're moving into that third box for physical therapist goals. And now I'm not a physical therapist, so if you guys wanna chime in and add more to this, I'd be more than happy to learn and to read some more about what the goals are for prosthetic patients. But with the experience that I have working with prosthetic patients and physical therapists as that team approach, these are like the top 3 that I felt were most important to address, at least in this presentation. So stretching, and whether that's pre-prosthetic or post-prosthetic PT, we've got to make sure that at all costs we prevent contractures, whether it be knee flexion contractures or hip flexion contractures, because that can make walking in a prosthesis a bit more difficult. Strengthening, core strengthening, and I think we could even add gluteal strengthening into the equation. We want to make sure that our patient is able to transfer weight from side to side appropriately once they do begin walking. And then balance, which comes from core strengthening and gluteal strengthening for single limb support. So next slide. All right, hopefully this lands somewhere, but nobody puts baby in the corner. Nobody puts prosthesis in the corner. The reason I put this in here and I have a picture of prosthesis in the corner is because we don't want our patients to put their prosthesis in the corner. We want them to use their device. We want them to be able to feel comfortable and trust their device and understand the different components of their device. So it's important for us as prosthetists to communicate how the device is made, what the patient can expect after they have it, and the journey from right when they get amputated or from that surgical procedure up until they're fitted with their device, which we're going to get into on the next slide. But before that, we have some quick stats. So amputation related to vascular disease is at top of the list of the cause of amputation, and that's over 50%, which is really high. And then 20 to 25% is trauma related, whether that be a motor vehicle accident or a fall. And then the third bullet point, tumor could really say cancer, but that's 4 to 5%. And then the lowest percentage is going to be a congenital limb deficiency or a limb difference that the patient was born with. All right, so starting at the very beginning, once the patient has an amputation. So what happens after this surgical procedure? We're waiting for the patient to heal, and that can take anywhere between 4 to 6 weeks. It can take longer sometimes, depending on if there are any vascular complications or what the mechanism of injury was. So ideally, the patient will have pre-prosthetic physical therapy and a pre-prosthetic consult. And during that consult, we are educating the patient on the next steps of their rehabilitation journey now that they are an amputee, and what that looks like and what they can expect. So we often discuss a shrinker and desensitization. So what a shrinker is, it's an elastic garment that's used to assist the residual limb in shaping and providing compression, so that when they do start to wear a prosthesis and they're casted for that, we have a nice cylindrical limb. The purpose is also to reduce the volume. After surgery, oftentimes the patient's residual limbs retain a lot of fluid, so we want to make sure that their fluid is stabilized before we proceed with the prosthetic process. Desensitization is a treatment used to modify how sensitive a particular stimuli is to an area. And so the thought behind this is that it makes it easier for the patient to tolerate a liner, a socket, and then weight bearing into their prosthesis. And different techniques are using different textures like a towel and rubbing it on the distal end, using tapping, massaging, or applying different temperatures to the residual limb. All right, and next slide, thank you. So we have our evaluation, and we'll run through this real quick. So we're listening to the patient's story. We learn everything that we can about them, because it's important to know where they're coming from. And it's important to us for them to know that they're understood. So with listening to their story, we ask questions so we can understand. We gathered this objective data, which is done by performing outcome measures, such as the AMP Pro. We're assessing the skin integrity of the residual limb and the contralateral side, because again, that's going to play a part into their rehabilitation journey. We're assessing range of motion and manual muscle testing and taking measurements. Measure twice, cut once, they say. So measurements are always good to have, especially in our field, because patients' volumes are changing a lot. Sometimes they don't change at all, but within the first 18 months or so, we're going to see the most change of the patient's residual limb from their amputation date to about 18 or so months out. And that can vary per patient, of course. And then at the end of the evaluation, we're going to coordinate with the multidisciplinary team, whether that be the patient's physician, their doctor, or the case manager. All right, and next slide, please.
Sarah, we have a question from Elena. Elena, do you want to unmute it in the chat?
Hi, Elena.
Hey, everybody. I have two questions, actually. There, on the previous slide, when you were talking about shrinker socks and some of that pre-prosthetic care, I was wondering, how frequently are you guys seeing patients that have rigid removable dressings or prefabricated rigid dressings, if you will. Are they still being used at this point? Or are you just doing kind of the shrinkers?
Yeah, that's a really great question. And I'm going to need some help with that question because I personally am not in a hospital setting. So I'm not seeing that many rigid removable dressings. But one thing I can say is that when I do go to a hospital, oftentimes I'm providing the patient with a shrinker. But Angie, can you help out with this question in terms of how often we see rigid removable dressings?
Sure. Yeah. It seems to go in waves a little bit. And it really depends on the physician and what their comfort level is. We do have, there are a bunch of physicians who do like to put someone in a rigid removable dressing as soon as possible, even before the sutures or the staples are removed. That does give some nice protection. Again, we only do these with a physician's prescription. So it's really the doctor or the surgeon that's driving this. But there are, and it kind of depends on the university system too it's going through. I see a lot going through University of Maryland, for instance, that are getting rigid removable dressings. But they're a nice protection. They provide one, if it's below, usually for your transtibials or below the knee amputees, it provides some knee extension, which is nice to keep reduce the risk of flexion contractures. But then it also just provide that distal end protection for falls. We see it very rarely with the transfemorals, the above knee, just because it is more bulky and difficult to keep on, where those shrinker socks usually work just better for that population.
Great, thanks. And then my second question, Sarah, was about the outcome measures. So I work with kids, and Rochelle joins me for our limb differences clinic once a month here. My question about outcome measures and K levels. So the AMP isn't validated for children. So do you guys have recommendations for, what kind of outcome measures we should be doing, if any, to help justify a K4 level for our kids? Or is it just understood by insurance companies that all, kids for the most part, unless there's other medical complexities going on, would be a K4, and we don't necessarily need to do outcome measures to justify their need for, a really great prosthesis?
Yeah, man, Elena, that's a really good question. And again, I'm probably gonna phone a friend, but I do want to answer it with this initially. So with that, especially like that pediatric to elementary school to middle school phase, oftentimes I haven't seen, and it depends on the insurance. It depends what state you're in terms of insurance approving a certain type of component, but I haven't seen much difficulty in that realm. But with like a high schooler, for example, and this was back in Virginia, but it was difficult to justify a running leg. And so one thing that we did do was, it was a brand new amputee, and for example, she was in a total knee in the beginning, and then the game plan that we had set forth was, let's get you into physical therapy. Let's prove that, one, you're wearing your prosthesis, you're able to use it, it's functioning appropriately for you, and you're tolerating it. So you're building this case. It's not necessarily like an outcome measure, but you are building this case of tolerance, that they can use the device. And then in terms of comprehension, if the patient themselves can comprehend going through an AMP Pro, then sure, we can try it to see if that works. But in terms of kids, Angie, Rochelle, if you're on here, this is kind of like a good conversation. Like, what can we do to prove to insurance companies that a certain component is appropriate for a child?
Yeah. So Mark is in here with me. He will take
I can
this
take that one.
Okay. Okay.
This one.
Yeah, so, boy, there I am. So I would say clinically, you can use the AMP and just modify it for the kid based on the age. I know we had worked on a modified AMP for children a ways back with Michelle and some other people at Kennedy Krieger, but you don't need a validated outcome measure necessarily for a clinical justification. You can still use it as a test. And more importantly, I would say if you're talking about high level function, the amputee mobility predictor has a ceiling effect and doesn't really sort out K4 very well. And so most of us realize that function level 4 is really justified based on activities. So if you can document in your note or the physician's note and the prosthetist note that this child really is active, they run, they jump, they're not active, right? They're not sick and with multiple impairments. This is really a kid who has the potential to be very, very active. That's way more compelling than an AMP score.
Mhm.
But if you want to go back to that modified amputee mobility predictor sometime, Elena, I'd be really interested in working on that with you. That would be fantastic.
That sounds great, Mark. Thanks.
Sure.
Elena, thanks for the questions. Appreciate it.
And I
Good
would
conversation.
just add, if I could just add one more thing, in terms of actual components and how insurance companies qualify K4 versus K3, there's literally only one component that is a K4 component, and that's a high activity knee frame. So otherwise, someone with K3 would qualify by the insurance for the same components as K4. So it is more important that it's the activities that are listed so that we pick the right components and be able to justify it for that. But great questions.
Thanks, guys.
Thanks, Angie. Thanks, Mark. All right, so let's go. Okay, casting. So I'm crossing my fingers that this video plays, and I actually have markers. Angie, I'm not sure if you're able to see the time on the bottom of the video once it does play. But what this video is showing is the casting process, which it's pretty fun for the most part. But what is involved is that the patient dons the liner, and typically there's a gel liner, whether it be silicone or urethane or TPE, just different type of gel consistencies and materials that are on the inside of the liner. And then there's that fabric outside. So we put that on the patient. We're assessing for pressure tolerant and intolerant areas, asking them if they have any hot spots that we need to be mindful of. And then we take measurements. The more measurements, the merrier sometimes. And sometimes if it's a patient you've been working with for many years, maybe you don't need to take any measurements at all because you know them, but it's important to always have a foundation. So at least taking a measurement of their skin before you even take the cast, that's going to be crucial for us so that we can document it accordingly. We put saran wrap around the liner so that we don't dirty the material with our plaster of Paris once we wrap the patient. But what you're seeing right now, that is a prosthetist drawing landmarks. So we typically find the patella, the fibular head, the anterior distal end of the tibia, and then a few more accent features on the tibia so that we can have that and it transfers into that negative model of the casting for when we modify. And we can also scan. So I unfortunately don't have a video for that, but plaster application is pretty cool, old school and traditional, but sometimes it works best for patients that have really difficult or unique anatomy. So I'm wondering if this video will play.
Sarah, I can get it to play on YouTube so I can stop my share and reshare if that's what you would like.
Yeah, let's do that. It'll take less than 2 minutes, I believe, just from the different points. Thank you, Angie. And if anyone has any questions, comments, suggestions in the meantime, I'm more than happy to chat through that with you.
Sorry, I have to fix it. I apologize.
It's all good. And I see that we do have 10 more minutes. I want to be mindful of everybody's lunch and kind of get through to the end of the appointment. But if I can just explain what this video was, it's the donning of a liner and it's actually a patient filming. So it's cool to hear her take on.
Hello! This week I'm going to share with you my experience during stump measuring and casting. Although the cast is made for my first prosthesis, but this ain't my first casting. My stump shrink by 5 cm, and that is the reason I have to come back for second casting. The first procedure will always start with stump measurement. This is to have your prosthetist choose the right liner to suit your stump size. Once he knows the size, then it's time to fit my stump with a liner. In previous casting, I was given a different liner. The liner doesn't fit me well and caused me phantom pain. Because of that, I requested my prosthetist to provide me with a silicone liner by Awesome. They call Ice Pro Spot Liner.
All right, so if we can go
Next
to
step is waist
250,
measurement. It is
Angie,
important for the
2-minute 50 mark. So at this point in time, you're seeing the plaster of Paris application. Here. Hey, Angie, if you could move the cursor up to the 250 mark. And then the next one,
I thought you said 150.
sorry.
Good.
Yeah, there we go. So this is plaster of Paris. It's almost like paper mache. We dip it in cold or warm water to start the reaction and apply it to the patient's limb. And then, Angie, if you can move the cursor up to 340. That's going to take us to the tail end of this, where the prosthetist is kind of finding some pressure tolerant and intolerant areas. The pressure tolerant area being the mid-patellar tendon.
Once the cast has dried, then it is time to put it off from my stump. There you go. That's roughly how my future socket's gonna look like.
All right.
Watching.
Thank you very much.
Give me a thumbs up and don't forget to subscribe.
Okay, her YouTube channel plug there. All right, so last step from evaluation to the diagnostic fitting after the casting is the diagnostic fitting itself. So if we can go to the next slide here. So I've got a bunch of tabs, and just time-wise, I wanted to be conscious of this. So the patient, we assess the socket fit with the patient, and that's this. We put it over their liner, and oftentimes it works really well. It's on, so we can attach it then to a foot and a pylon. There's another component here that I don't have, so we're going to imagine that it's there, but it's going to attach the pylon to the bottom of the socket. And once we have this full configuration, then we can have the patient stand safely within parallel bars or using a walker. Oftentimes, once the patient is up and standing, we're assessing for any pressure points. They're giving us feedback. We're looking at how the trim lines are on the socket, the trim lines being the back, the front trim line, the side trim lines, how it's interacting with their anatomy. And we ask the patient to shift weight if that's possible. If we're checking all these boxes, they're able to tolerate their weight bearing, they're able to shift weight, and the prosthesis is nice and secure, then we can have them to take a step with the parallel bars. And then strength and endurance wise and balance, these are all factors that we are aware of, and we take that into consideration when we do suggest or recommend a patient take a step in the parallel bars. All right, so next slide, team approach. So we're coming to an end here, and we know that there's more people than this trio, like the physicians, case managers, the surgeons, on our end, manufacturers that build prosthetic feet. But again, I want to focus on the prosthetist, the patient, and the physical therapist. So on the next slide, we have the prosthetist job and goals is to evaluate, educate, and provide a prosthetic device to the patient. The patient's goals, whether it be standing or walking, once they've achieved that through the use of their prosthesis, they're going to physical therapy for gait training, because sure, the patient can walk and take a step, but what does that step look like? Are they trunk leaning? Are they presenting with gait habits, poor gait habits that should be rectified? And then we have physical therapists that are going to guide our patient to appropriate and safe movement, and then assist also in prosthetic education. So next slide here. All right, guys, I wanted to throw this in there. So if you think you know everything, you know nothing, lousy. And then you know nothing, Jon Snow, for any of my Game of Throners out there. But just when you think you've cracked the code, there's always a patient that is going to throw a curveball at you that will either exceed your expectations or not. So that depends on their motivation and what expectations you set forth for them. And as long as you all are traveling that road together and communicating, we can make sure that we have a successful result for both parties, so the patient can use their prosthesis. All right, let's go to that next slide. All right, how are we doing on time, Angie? 3 minutes.
We've got about 2 minutes.
Okay, excellent. So I wanted to deep dive this slide, but I'm gonna just brush the surface. A willingness to learn. So it's important in our field and in our lives just to have a willingness to learn. As prosthetists, we study, assess, and implement a prosthetic design or componentry based on what the patient's history tells us and based on their outcome measures. We listen to user preference and we listen to user experience. So what that means is if a patient's a long-time patient and they've been using a certain foot for a long time and all of a sudden they're not happy with that foot, we use our expertise and our clinical assessment of the patient to say, okay, let's get you into something that's either more stable or something that has more motion. And I found this article and it was really neat. It talked about ankle stiffness. And according to Kleitz, these researchers used criteria such as joint work, muscle activation, limb power, self-selected walking speed to determine the best ankle stiffness for the patients in the study. And the last bullet point, I thought it was nice and a refreshing bullet point, but users likely benefit from their direct perception of the device's interaction with their body, derived from the vast array of physiological information available to them. So I've had patients that are athletes and they just take off and they're walking and they're doing a great job. I've had patients who aren't athletes do the same thing. They just have a really good understanding of body awareness and proprioception. So it's an important reminder that even though as prosthetists, we historically have known this foot to work well for a certain patient presentation, it's up to the patient to tell us and let us know, hey, how's the foot working for them? And does our alignment need to change? And things like that factor into the equation. So, next slide. All right, so in summary, we want to set expectations. We want to be clear about communicating those expectations. Listen, it takes a team. We couldn't do this without the help of physical therapists, without our doctors, without our colleagues, without the patient. So we know we are successful when the patient returns to the activities that fulfill them. And lastly, let's go to the final slide. Expect the unexpected, y'all. Sometimes just when you think, again, like you've cracked the code, something throws a curveball. So it's important, as long as we're listening to our patient, as long as we're communicating, setting the expectations for, hey, you're super motivated to do this. I also ask you to give yourself patience because there will be frustrations along the road. There will be areas that we need to fine tune so that we can make this pathway, this journey of prosthetic rehabilitation, a success for the patient so they can walk and achieve their goals. All right, so next slide. This is resources in case anyone's interested about the resources used in this PowerPoint. And then finally, Next slide. A big thank you to everybody. Thanks for taking the time out of your day to tune on in. We will have another one in February, so stay tuned via email. We'll send one out once we are ready and set. And now we welcome questions, comments, or suggestions for next topics.
Yeah, thank you all for coming. I know in lifetime, feel free to hop off. We did have Evelyn message in the chat and said on the slide about PT, she can provide her experience. She works in a subacute rehab with adults at times for people post amputation, and often they will focus frequently on transfers and standing tolerances goals before they fitted for a prosthetic, and always need to relate back to function. So I think that's really good. And thinking about where are they in the process. The amputee mobility predictor, both the AMP Pro and the AMP No Pro versions can be good for figuring out those specific tasks too. I've had a patient that was K0 to start, but was really looking to be K1. And so we were using some of those basic movements like standing and transfers and like working on those to be able to get her to that K1 status. So that's right where you want to start if you're at that level for sure. Thank you, Evelyn. And thank you all. Elena, again, great questions earlier, and we hope to see everybody next month.
All right. Bye, everyone. Take care.
Bye.